So we're going to talk a bit about complications of regional anaesthesia. It's always controversial. If you want to have a fight, wade in, that'd be fine. Have a go. But we'll just try and talk about some of the evidence that's out there so we know what we should be talking to our patients about and what's likely to be happening. In terms of getting it wrong, I mean, if you haven't heard it before, this has been trotted out a million times, that if there seems to be a problem with a regional anaesthetic technique, the first place to go looking for the cause of the trouble is on the proximal end of the needle. I think the actual quote was, "You should look at the prick on the proximal end of the needle," but I didn't want to, I didn't want to put that on the screen. Just so you're clear, that's the proximal. What can happen? It's a question. What's the worst thing we can do to someone with a regional technique? Kill them. Okay. After that,
Disabled.
permanent disability. Okay. How can we kill them? So systemic toxicity and
CNS injection.
yeah.
CNS infection.
With that systemic toxicity we've done. There's another. If we're going to look at serious complications are very rare, and that makes them difficult to handle. It's difficult to quantify, it's difficult to know how to avoid them, it's difficult to deal with generally. So if you're going to try and get to grips with serious complications, you need a huge database. And there are a handful of databases out there now. The American closed claims system has been going since the mid-1980s. They first reported in 1988. Are you familiar with the American closed claims system? Robert Kaplan and a few of his mates were trying to get to grips with some of these serious complications, and they went to the insurance companies and said, will you let us read all about your patients who are suing us for being badly damaged, because that's a good place to go looking for serious complications? And they said no. So they had a bit of a negotiation, and they agreed that they could have a look at the notes. So what about large data? And 2002. So this was the first alarm bell. This was 1988, and this was Robert Kaplan's group. And these were the guys who looked at all these medical reports from the lawyers. When they said, "Can we have a look?" 900 reports landed on their desk. Thud. Group of patients. At time zero, when the collapse happened, the first clues they had were sudden bradycardias and crashing hypotension. And when they looked into it, they were actually quite surprised, because most of these patients were ASA 1 and 2, people under 60, under 50. So they were actually fit and well patients who you would not expect to have trouble with spinal anaesthesia. This is their stylised resuscitation of a cardiac arrest after their spinal anaesthetic in 1988. Time zero is the cardiac arrest. -5 to 0 is the 5 minutes before the arrest, and this is the 10 minutes afterwards. What surprised them, what they were expecting to find, was that people had had shitty anaesthetic care in the 10 minutes, 20 minutes leading up. They've been ignored, they've been sedated and respirated. All the patients has had exemplary anaesthetic care. That surprised them, because they're young fit patients who are actually looked after brilliantly well until at least 90 seconds before the event. So adequate anaesthetic care up until a minute and a half before the event. Then the first clue, which was either bradycardia or severe hypotension, and then they had ephedrine, atropine, CPR. Can you see that they didn't get a proper vasoconstrictor until somewhere between 7 and 8 minutes? And in hindsight, they think this delay to having a vasoconstrictor probably accounts for the appalling outcome. I mean, if we had 14 cardiac arrests from spinal anaesthesia, you wouldn't expect 13 to be either dead or, severely neurologically damaged. So in hindsight, they thought this delay of using vasoconstrictors was probably contributory. Although they did use atropine fairly early on. This work has been followed up big time. because this really, I mean, this they had an editorial in Anaesthesiology. There's a lot of talk about this. We've got young fit people having arthroscopies under spinal, and they're dead. And there was one less than 10 years ago, a 17-year-old in Sweden had a spinal from arthroscopy and has sudden cardiac arrest, unresuscitatable, dead. So there's something going on that's at the ordinary. How big a problem is it? Well, other people have looked at it and written about it. Brian Pollard is the guy who's done most look at it. But Eva Roy's first big study in cardiac arrests, that Pollard is the guy who's done most of it in the last 10 years. And he pulled data from a variety of places and still found anaesthesia. And the Mayo Clinic reported all their neuraxial blocks. So what's going on? There's been lots of discussion about it, and I still think it's relevant today. And I will bore people to death if they come to my theatre and talk about what is happening to this special group of patients. And the general features are that they're young, fit patients having surgery from the umbilicus to the pelvis. All was good until they suddenly had an arrest at around 30 minutes, and they had poor outcomes. And it looks like what's going on is a bit beyond normal physiology. We all know that if you have a spinal, you get a bit of sympathetic block, you get a bit of hypotension, you might get a little bit of bradycardia, a little bit of poor venous return, but nothing you can't fix with a bit of volume and a few little bits and pieces. We're used to that. That's our daily life. The sympathetic block obviously goes higher than the sensory block. So the vasodilatation in your lower the block. When you start to get a block going up into the cardioaccelerator fibres and you start to get bradycardias and marked reduced sympathetic tone, you can get very severely reduced venous return, which can induce cardiac reflexes, which is why you get a sudden catastrophic collapse. And the trick here is if you get a young, vigorous heart that's beating on very empty, so they've got very poor venous return, there is a reflex. I mean, they used to think it was the Beehole-Jarisch reflex. They've changed their mind about that now, but they think there's a left ventricular reflex that says, if you're going to make me flog my guts out with no venous return, do you know what? Up yours. I'm going to stop. I'm going to go complete asystole, and I'm going to stop beating. And teleologically, the explanation was the heart was trying to say, I'm stopping to try and improve my venous return. When my venous return comes back, then I'll start beating again. So what they think people were dealing with was a left ventricular-based reflex that was particularly prevalent in young, fit people, vigorous hearts. If you've got a crappy heart, you can't really go on strike, but a vigorous heart can definitely go on strike. And you've got severely increased vagal tone, severe bradycardia stroke asystole, and vasodilatation everywhere. Your upper body vasodilates, your lower body vasodilates maximally, and you're in trouble. The Americans had seen this before because during the Vietnam War, they tried to bleed out volunteers when they were looking at shock hemorrhage. So they took young, fit volunteers, I don't know who the hell they were, but they took 500 ml aliquots of blood out of them. And they wanted to look at their cardiovascular responses as they basically tried to bleed them to death. Obviously, they kept their blood to give it back to them later. But what they found was that with these young, fit guys, they'd be okay, 500, a litre and a half, 2 litres. You got to a point where they were so empty that they did this. They got a profound bradycardic asystole all within 10 seconds, and they basically had a cardiac arrest, and you had real trouble sorting it out. And what you need is professional drugs. This is not something for glycopyrrolate and a bit of ephedrine. This is atropine, serious vasoconstrictors, and lots of volume quickly to get it sorted out. Having said that, have any of you got experiences of people who seem to have a very dramatic response to a spinal, profound hypotension, really nauseous, like out of the ordinary, and you think, oh shit, and their blood pressure's 50, they're sweating like crazy, and they're almost going unconscious on you. Is that a common experience or an occasional thing? No, I mean, I've got no numbers to suggest how common this is, just that it happens, and if you don't recognise it happening to you and don't pile in with the big guns immediately, that's how you get yourself. So we had treatment. It's still with us. It's controversial, and there's plenty of editorials been written to talk about it. And drugs. Levobupivacaine, how safe is that compared to bupivacaine? Yeah, it's 25% safer. It's not safe. It's perfectly possible to polish people off with levo. So you just need 25% more levo to produce the same effects. Ropivacaine, it's safer, but it's not. They're not safe drugs. You can't use them with gabapentin. So in terms of the frequency of systemic toxic reactions, epidurals is probably about 1 in 10,000. Peripheral nerve blocks somewhere between 1 in 500 and 1 in 1,000. So I have seen incidences as low as 1 in 200. So action plan, airway, breathing, circulation, fitting, ignore it to start with. Probably your propofol when you intubate the patient will sort that out. With the long-acting ones, you need to be prepared to resuscitate them for 90 minutes. I haven't got it, but I've got a slide of all the drugs used in someone who they tried to resuscitate in 1970. They had every single drug because it was very difficult. If you get low output states, some people don't like adrenaline. So if adrenaline doesn't seem to be doing much for you, fairly early. If you've got cardiopulmonary bypass, you might calcium channel blockers. This is an old slide. This was before it had been used, and I put this up just to show you where we were in 2006. I was offering people weird but spectacular, and then of course Meg Rosenblatt treated a guy with it in New York, and it turned out, ever since then, everyone knows that intralipid is a very effective antidote. What I love about Meg Rosenblatt's case report is that she gave something like 60 milligrams per kilo of lipid to this guy, and he was fine. So, our initial limit was 8 milligrams per kilo, and then it was 8 mils per kilo, and then it was 12 mils per kilo. She gave 60 mils per kilo. There's no mucking about. They got huge boluses and lots of stuff. So obviously we've now got national guidelines since 2010. Bolus, infuse, wait 5 minutes, further boluses, increase the infusion, and that's your maximum dose. And I don't know of a case yet with cardiovascular collapse where they didn't manage to bring them back. Has anyone come across one on lipidrescue.org or anything like that? Okay, so anytime you work in a new hospital, do you figure out where the intralipid is quickly? It's the first thing I do. Before I pick up my syringe of bupivacaine, I want to know where the intralipid is. So every hospital I work in, I try and figure out where it is, because as sure as it happens to you, you'll be with the agency ODP who started work this morning and doesn't know where it is. Did any of you get involved in that hilarious exercise where they asked us where we kept the dantrolene? They walked round theatres and they asked everyone, anaesthetists, ODPs, everyone, where you keep the dantrolene. And old farts like me had no bloody idea, because I rely on if I get malignant hypothermia, I'm going to stay with the patient, send my ODP. So I was walking out. It was a comedy, but that was fun. Okay, temporary nerve damage. We've said it's common. It generally resolves within 2 or 3 months. I actually tell patients, but I tell them you might get a funny numb patch and it'll go away in a month or 2. That saves them the hassle of, I've got a funny numb patch, what do I do about it? Oh, they said I might have it and it should disappear. And brachial plexus blocks. Permanent nerve damage is difficult to know what to say. I tell patients 1 in 5,000 to 1 in 10,000. Permanent nerve damage after peripheral nerve blocks. That's based mostly on Roy's 2 papers, where the incidence was 1 in 5,000, 1 in 7,000. A couple of things, it's 1 in 11,000. So it's there or thereabouts. I think patients need to know that it's possible. They need to know they don't have to have a peripheral block. There is an alternative. And then we get on with it from there. What do you tell patients? Risk of permanent damage? Do you put a number on it? Just say it's rare. For central axial blocks, it's different. But for peripheral nerve blocks, what do you tell them?
Just say it's rare.
Okay. I mean, I haven't been able to. I've been using that number. What do you tell Manand about saying? Or
I just say 1 in 5,000. But what I want to say is that it's difficult to put a number on it, because it depends on how the person does the block as well, his experience.
Yeah.
And how he does it. So 1 in 5,000 for one person may not be right for the other person who has 1 in 5,000.
1 in 100. Yeah. But the other problem is, how do you define permanent nerve damage? Because that could be a little numb bit that doesn't really bother you, or complete quads weakness that destroys your life. It's to tell them that they're going to have catastrophic. It's a bit like NAP3. There's catastrophic and death, and then there's permanent injury that your quality of life is affected, but you can. So why do we get nerve damage? Well, mechanical. Intraneural injection disrupting nervous tissue. Hematoma. Ischemia is a big one. It's a big one for the spinal cord. A lot of the problems you have with permanent spinal injury Stopped.
It's not a really dumb question.
Yeah.
I'm just trying to work it out. If you've blocked their leg
Yeah.
and you've got local vasodilatation and you're measuring the systemic map on the cuff on their arm, are you definitely getting, if their central map has gone down for whatever reason, you've given them a GA as well, might your perfusion pressure in the leg that you've blocked therefore be even lower? Because the resistance in that leg is a lot lower.
It might be, but what you, for a kidney or a brain or a heart, the pressure is going to be important.
Mm.
For this, you're talking about, is there enough flow going on?
Mm.
And then you've got the problems between cycling between pressure and flow. So even though the pressure's down a bit, what's the flow like? I suspect for the spinal cord, it's very dependent on pressure. But for the peripheral nerves, I don't know what to say about that. So peripheral nerve damage, there's 3 flavours. The one you want is neuropraxia. Those ones are generally conservative treatment. You just monitor it and see what's going on. If you've got transection and neurotemesis, then you probably need some kind of surgical treatment, and you probably need it within 6 months. So if you wait more than 6 months, you get irrecoverable muscle damage at the end of the nerve. So intraneural injection, you probably need to put some local in here. And the Americans have done work with dogs where they deliberately impaled a nerve, but they didn't know whether the needle was here or here. They knew it was in the nerve, but they didn't know where. And then they did injections and measured the pressures, and they had 2 kinds of issue. Some of the dogs they did this to had a very low pressure injection and no neurological damage, so they thought that needle must have been there. Other dogs had a very high pressure injection, and then they had permanent damage, and they thought that that must have gone in there to account for the high pressure. The snag with the high pressure is that it's transient. You put lots of pressure on, and the magic number is 25 psi. You put lots of pressure in, and then you blow this nerve up completely. You disrupt the barriers. So then you're back to here, which is why your ODP, who squirts the first 3, 4, 5 mils in really hard and fast, and then says, oh, it feels fine, you don't know that they haven't blown up an axon, and the reason it feels fine now is because you're basically giving one of these injections by virtue of destroying this barrier. So if I'm working with ODPs, particularly big guys who I don't know very well, I'm really nervous. And I'm in their face about how to do the injection. One thumb, really slowly. It's not, and if I see the heel of the hand coming out, it's like, whoa, stop. Because I think, you need to have a bit of finesse about that one. So we talked about peripheral nerve damage and the let's just shift. What I really want to many ways to achieve similar ends. What do I tell people about? Benefits yet, risks yet, common, serious, any of them I'll talk to them about. And they need to know they're all. There we go. So I tell everyone about failure and damage, temporary and permanent. And then some people I'll talk to about infection, hematoma, and specifics to do with the block. You have to be careful. If you actually told people about every complication of interscalene block, do you think anyone would ever have an interscalene block? I mean, we just do it at the wrong time. You meet them on J3, right, this is really good, but I could do this, and this to you. So I tend to tell them some of the things beforehand, like damage and that. Things like Horner syndrome, hoarse voice, I'll often tell them at the end. I'll tell them in recovery, now look, when you... I mean, that's been reported. Do you tell people they might get a bowel perforation when you do a tap block? So I think we're slightly selective and on the common things. So should you mention accidental? Do you talk to people about systemic toxicity? I don't. But if it's 1 in 200 to 1 in 1,000, maybe I should. Do you tell them about IV toxicity? Um, all the weird things that can happen there. And we talked about all the bizarre complications you get with lumbar plexus blocks. I think since we turned it into a nerve stimulator technique, often much safer thing to do. So this is most of the stuff in the American closed claims. So their first report in 1990, 15% of anaesthetic sewings was related to regional. The top contenders were ulnar and brachial plexus, usually without regional technique. Lumbosacral roots and spinal cord damage was 16 and 6%. When you compared that with later, ulnar and brachial plexus was still up there. Lumbosacral roots and spinal cord had started to increase. So there's a common pattern. We damage these nerves with positioning, and we damage these nerves with regional anaesthetic techniques. You won't have experienced 1991, which was a major year for us lot. Do you know what happened in 1991? Revolutionised anaesthetic practice. Any ideas? So the report came out in the BMJ about pain after surgery, and it told us we were all crap at post-op. I mean, literally said we're all crap at post-op pain relief. And to a certain extent, you can see that they were right. I mean, patients who were having major laparotomies, been written up for 10 milligrams of morphine 4 hourly. The patient had to yell, ring for a nurse, wait for the nurse to go at the cupboard, come back, It was at least an hour between ringing the bell and getting any decent pain relief. It lasted an hour and a half, and then you had another 2 hours waiting for your 4 hours to be up before you rang the bell and waited another hour. It was a disaster. And the two things that came out of that were PCAs. I went abroad in 1990 and I thought I'd land on a different planet when I came back. Because everyone was having PCA. I'd never seen a PCA. What's this PCA? Giving yourself morphine, it's cheap. And epidurals. There was an absolute explosion in using epidurals. And for me, just gets. Is it at your fingertips? All the numbers? Okay. 1 year, 700,000 central neuraxial blocks, 84 major complications. So if you take all comers, the risk of death or paraplegia is somewhere between 1 in 50,000 and 1 in 140,000. And of getting permanent injury is somewhere between 1 in 25,000 and 1 in 50,000. But if you have a perioperative central neuraxial block, the risk of death or permanent injury is closer to 1 in 12,500. And if you have an epidural, if you look at epidurals alone, the risk of having death or permanent injury is closer to just under 1 in 6,000. So actually, if you're having perioperative nerve block for perioperative pain relief, that's a kind of special case. And that is in chapter 14. To the end. I just stuff on the NHSLA. Sorry about this, guys. Okay. So this is Tim Cook in Anaesthesia in 2009. And what they were looking at was that of that 40,000 claims, about 1,000 of them were for anaesthetic related problems. So this was surgeons, physicians, obstetricians, this was everyone. Our group, at fifth in the league table of causing trouble. The big three for us were death, inadequate block, and permanent neurological. So of the 40,000, obs and gynae was the worst. That was their claims. Surgery was second worst. Medicine was there. Emergency medicine was there, and we're on a par with psychiatric and mental health in terms of complaints. So bear in mind that in that 12-year period, there were 1,000 claims involving anaesthesia. Sorry. So epidurals were 72% of claims, spinals were 15%, and CSEs were 2%. Peripheral nerve techniques, 10 claims. And most of these weren't for nerve damage, they were for pneumothorax and stuff like that. Okay? So actually, there's a common theme. Central neuraxial blocks carry high complication rates, and peripheral nerve blocks carry low complication rates.
I think that's just, we probably do more epidurals and spinals than peripheral blocks, don't we, probably? So numbers-wise, if it was adjusted for the number we did, do you think it would be a bit more, would that change? Because these are absolute numbers, aren't they?
It's when you look at the big, I take your point, because it's actually quite difficult to know how many we've done. When they were trying to work out how many spinals they did, they actually resorted to contacting the companies to work out how many ampoules of heavy Marcaine had been sold to hospitals and saying each ampoule equaled a spinal. They could not find it. Yeah, they were struggling to find denominator data for the UK. They had their numerator data from the suings, but they didn't know how many they were talking about. The short answer is when you look at studies that control for that, so Eva Roy's study, they had 20,000 peripheral blocks and 40,000 spinals, and the difference was enormous in terms of complication rates. They had very few complication rates. So they had like 34 big complications in the spinal group, and they had 4 complications in the regional anaesthesia group. And if you double the size of the regional anaesthesia group, peripheral nerve block group, it would be 8. So there is a big, if you take it back from there, that those would suggest it's a real difference. So 10% of these alleged inadequate consent, and these are obviously the big three for us. If you look at complications by severity, there were 8 deaths. All these deaths were non-obstetric epidurals. And severe, moderately severe, mild to moderate. So there was a fair spattering of degrees. They made a big play of the difference between obstetric and non-obstetric. So if you look at obstetric patients, they get upset for inadequate block. This is called awareness. Okay, you can be aware during a general anaesthetic, or if you have a spinal and you feel pain, that's classified as awareness in most authors' books. So the number one cause of trouble in obstetrics was actually an inadequate block, followed by this lot. If you look at the patients having non-obstetric sort of perioperative stuff, it's nerve damage and infection. Don't ask me what that's all about. I don't know where they got. I think at some days when they used to do funny nerve eye blocks and not put sort of solutions in. And those are the sort of numbers to go with it. So there's a difference between obstetric and non-obstetric. We know that from NAP3. I think you'll find this is where Tim got the idea for NAP3 from, because Tim did this work before he set up NAP3. For the top 28 claims, 26 out of 28 top claims are for neuraxial block, and that's epidural, spinal, CSE. That, if you look at people who are claiming for death, then regional anaesthesia is relatively low down. And can you see airway management? What was that? NAP4. I think central venous cannulation and respiratory issues are going to be NAP5 or NAP6 and 7. Okay, because I think this is where Tim's got his targets for NAP from, because he did all this work to find out where the trouble was, and now he's trying to hunt down and characterise the trouble in the UK. So that's NAP3, NAP5 and NAP4, and that's why I said I think respiratory and central venous cannulation are going to be 6 and 7. This will be aspiration, pneumonias, all that kind of thing. There are a surprising number of deaths from central venous cannulation. It's more dangerous than you realise, because if you manage to puncture an intrathoracic vein, it often goes unrecognised until it's too late to really fix it. And final bit, if you look at the claims for 1995 to 2007, for every 100 claims that came up, 40% of patients abandoned it, 40% settled out of court, 4% went to court. Of the ones that went to court, 2/3 found for the NHS and 1/3 found for the patient. 14% are still pending. So, anything controversial? Anyone to shout at me about? Oh, come on, there must be something you want to disagree with.
Issues of consent.
Yeah.